2021 of the Andean Health Organization Hipólito Unanue Agreement. It's already 3.5 years of continuous interlearning since we started in May 2020. Mental health is vital for humanity, as it allows us to lead a full life and contribute to the development of our community and country. However, 1 in 8 people worldwide have mental health problems, and women and young men and women are disproportionately affected. 3 out of 4 affected people receive inadequate or no treatment, and many face stigma and discrimination. Today, Thursday, May 2, 2024, we will hold the third webinar we developed with the British Embassy. This time, we have experts who will share the British vision on mental health with the aim of promoting an exchange of knowledge and broad analysis of the topic. We should highlight that for the Andean Health Organization, the Hipólito Unanue Agreement, promoting health and well-being of the nearly 170 million Andean inhabitants is a priority. We work hand in hand with the Ministry of Health so that public policies respect, protect, and promote human rights, being inclusive, equitable, and based on respect for human dignity. We firmly believe that the One Health approach is indispensable to achieve the highest level of health. What we do now depends the development and well-being of our population. Reflections on these and other priorities relevant for health and well-being can be found in the bulletin Noti Salud Andinas, monthly edition, available on the website of the Andean Health Organization and in the Andean Integration Knowledge Showcase. We invite you to read them. Now, we invite you to leave your name, organization, and country from which you're joining us through the comment box of the Facebook or YouTube live chat. To access the certificate of attendance to this webinar, as usual, you must fill out a brief survey and leave your data in the fixed link found in these chats. We remind you that you must verify that your email is spelled correctly. Thank you very much. Also, through this same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. This webinar has a particular dynamic. We will start with institutional greeting, followed by the keynote presentations, then the comments of the presentations, and then start the dialogue through questions and comments from the experts present in the room. To begin this important day, I give the floor to Dr. María Carmen Calle Dávila, Executive Secretary, the Andean Health Organization Hipólito Unanue Agreement, who will give the welcome and institutional agreement. Go ahead, Dr. Calle. You have the floor. Thank you, Gloria. Well, very good morning, good afternoon, good evening, depending where you are. Today we present webinar number 3 that we have organized with the British Embassy in Peru. I'm very happy with this cooperation. And it's also webinar number 221 since we started this weekly broadcast in May 2020 with the aim of promoting continuous interlearning. On this occasion, we will learn about the British vision on mental health. Mental health is a fundamental aspect for the well-being of people. It is not a privilege. All people should have access to quality mental health services, as it is vital to lead a full life and contribute to the development of our community and country. In 2019, 1 billion people among them 14% of adolescents throughout the world were affected by a mental disorder. Suicides accounted for more than 1 out of 100 deaths, and 58% of them occurred before the age of 50. Mental disorders are the leading cause of disability and are responsible for 1 in 6 years lived with disability. Social and economic inequalities, public health emergencies, wars, and climate crisis are among the structural threats to mental health present worldwide. As a result of the cases of prolonged COVID, the increase of deficiencies in the determinants of mental health and the interruption of mental health services, there was evidence of an increase in the prevalence of mental health disorders, 35% depression and 32% in anxiety, affecting mainly the most vulnerable population, including the frontline health personnel. Despite the fact that mental health disorders increase the risk of other diseases and contribute to unintentional and intentional injuries, the median public health expenditure on mental health in the region is only 2% of the health budget, and more than 60% goes to psychiatric hospitals. Investing in mental health is crucial to promoting equitable and sustainable human development so that all people can live with well-being and dignity. For every dollar invested in expanding treatment for depression and anxiety, there is a return of $4 in improved health and ability to work. We must act to rebuild better mental health systems and services. We must all stand up for the rights of people with mental health problems and provide the care necessary for their recovery. This includes having public policies that support mental health education, stigma reduction, access to quality care, and the creation of more supportive and resilient environments in society. In that sense, in order to contribute to the improvement of mental health of the population in the Andean sub-region, the ORASCONU has the Andean Mental Health Policy, is implementing the Andean Mental Health Plan, has organized mental health webinars, and has developed 2 international mental health congresses, and the third one will be in December of this year. This webinar will feature 5 professional experts who will highlight the British vision of mental health, advances and challenges, which will contribute to reduce existing inequities and gaps. Thank you very much. Welcome. Thank you very much, Dr. Calle, for your words. Now, Mr. Rodrigo Acevedo has the word on behalf of the British Embassy in Peru. Go ahead, Mr. Acevedo. Thank you very much. Welcome, everyone. It's always a pleasure to have the Andean Health Organization here with us and have the Ministry of Health here too. It's a pleasure to be with you once again. This is the third webinar we work together, and once again, we thank this is a national reinforcement of continuing being a priority for us in Peru. We have seen how previous webinars had a great impact, and we hope that this is going to be a similar case. Dr. Calle has shared important statistics about the impact on this issue on the life of person, the population, and the Peru's development. So we hope that today's presentation And we'd like to ask Paul, Sofia, Paul, Sean, and everybody else in this speech through your comments in the webinar, well, in the contact information. Please come to us with any doubts, questions for the following organizations that we work together. Thank you very much. Thank you, dear Rodrigo, for your words, and thanks for this welcome. After the institutional greetings, I introduce myself. I'm Gloria Lagos, Manager of International Cooperation and Coordinator of the Mental Health Committee on ORASCONU, and I am pleased to be in charge of moderating this webinar. We begin the conferences of this webinar, British Vision on Mental Health Advances and Challenges. For that, we welcome Dr. Sean Cross, physician, lecturer in education from the NHS. Go ahead. Dr. Cross, welcome, and you have the floor.
Muchas gracias. Hola y buenos días a todos. Muchas gracias por invitarme a hablar hoy. Espero que la próxima vez sea en Lima. Lamento que mi español no sea muy bueno, por lo que voy a hablar en inglés en la presentación. It's a pleasure to be here. My name is Sean Cross. I am a clinician working in London, and I'm in the middle of my shift in the emergency department here at King's College Hospital in London. And I'm also on the executive of my hospital, which is the Maudsley Hospital here in central London. I would like to be able to spend 10 or 15 minutes now giving you an overview of my hospital. It was lovely to hear the introduction just now from the panel, because everything that was said, I agree with wholeheartedly. The importance of dealing with mental health in our healthcare systems is enormous and is a growing problem. I work at the Maudsley Hospital in central London, which I'll tell you a little bit about from a historical perspective in the few minutes that I have. And I'm going to focus on 2 or 3 areas that I work on in particular. But we are an organization that is extremely interested in international cooperation, as you will see from my presentation. And it would be joyous to make further links in Peru and across the Greater Andes region. This is a photo of the hospital where I'm working at the moment, and this is a little bit of the history. We date our history back 800 years. We're the oldest mental health institution in, we think, in the world, although in Babylon, I understand in Iraq, an organization says that it has been going for longer. One of our other hospitals, the Maudsley Hospital, was the first hospital in Europe to be set up not just as an asylum, but to assess and treat mental health problems. And it's always been a source of innovation, and now is one of the largest research units globally for mental health and the largest psychiatry training program in Europe. And this is who we are. We are a world leader in the development of services and of research and training. But we are doing 2 things. We're trying to connect more globally, but also work out how we embed our services much better in the local community, because to enhance mental health for one person, it's necessary to enhance mental health for all. And this is where I think as psychiatrists and mental health practitioners, we vary a little bit from some of our acute medical colleagues. We're thinking at a population level and thinking how we don't just treat the symptoms, but how we try and help our patients to flourish is so important. Our trust, our hospital, in other words, is a large one. We have 6,300 staff. We cater for 1.3 million people. We have around 700 beds and many community services as well. And our strategy, as you can see here, recognizing the importance of everything I've just said, is not just about delivering high quality mental health care, but is also thinking about how we prevent mental health care with work with young people and in schools, how we are a catalyst for change in our local community, how we build a culture of trust together, increasingly recognizing that there are many inequalities, in particular in South London, across racial divides, leading us to all kinds of problems in mental health care around institutional racism. And of course, how we become a more sustainable service as well. This is a little map of South London. That blue line is the River Thames, and we offer care to many people across this giant city of ours. But we also work hand in hand with our university at King's College London and have a whole series of research programs on offer around mental health. So let me tell you a little bit about some of our local services. I'm going to talk about local services, our national services, and then a little bit about our international services as well. So as we heard with the dreadful epidemiology that was described at the beginning of this seminar, working out how we offer services right across the age range, from child and adolescents through working age and through to older adults as well. We group our services around ages, but recognize that there are a whole range of reasons why people at a young age is where we need to focus, because there is reams of evidence now that investing in prevention around mental health difficulties in the under fives will prevent a whole array of problems later in life, some of which I'm going to talk about. I'd like to talk a little bit about population health. And this is something that isn't just about recognizing that certain conditions exist in a local area, but we have developed a very innovative tool which allows both primary care physicians and psychiatrists and public health doctors to be able to understand the population that has severe and enduring mental health problems. And this that you see on the slide here just now is it in action, as a clinician would use. And the dots that you see coming up very shortly end up being those people with hotspots with large numbers of people with schizophrenia. So this tool that is available both for mental health hospital and primary care enables a population view, but also to get data on a pathway view, a caseload view down to a doctor or a nurse, as well as an individual view. And through this, start to have an impact on some of the dreadful mortality data that is available locally with us, as in most places globally. If you have schizophrenia, you're likely to die somewhere between 15 and 20 years earlier than if you don't. And integrating mental health care into this wider healthcare network, I think, is one of the most important things to do globally, whether in physician primary care level or whether in our larger hospitals. And I had the privilege of leading the Mind and Body program that focuses very much on these mortality and morbidity differences. So not only if you have schizophrenia, you die younger without it being a pathology that kills you, but for example, all the long-term conditions that every country is grappling with, non-insulin dependent diabetes, a classic example. Many years are taken off someone's life, in particular, if you don't spot depression and anxiety. But many of our diabetologists are not trained to do so. This gap between mental, physical, mind, and body is exactly what we're trying to impact, and that means embedding psychiatrists, psychologists, and other mental health professionals in hospital pathways like heart failure and diabetes. We have a range of national services as well, mother and baby services, eating disorders, the prevalence of which is increasing, as well as national psychosis and autism services. And we have started in the last 5-6 years to have international work as well. And so we now, through our joint venture called Maudsley Health, run inpatient and community services in both Dubai, Abu Dhabi, and the Northern Emirates. And for us is a model for how we link the work that we're doing back in London with the delivery of healthcare in local systems. And we'll be very happy to talk more about this to anyone who is interested. We train a very large number of psychiatrists every year. We have a couple of hundred training programs for residents and higher specialist trainees. And we also offer international fellowships for people to come and work in London, both in our clinical services and research units, as well as shorter term observerships. So fellowships for 1 to 2 years and observerships for 4 to 12 weeks. And we would welcome people to come from anywhere. The website here is maudsleyllearning.com, also offers a variety of training, and we have a whole host of training, from traditional webinars and face-to-face training through simulation training through the use of actors, which we do online as well. And we have a whole host of programs around virtual reality training, which I would welcome any collaborators in South America. I would like to end there because I think we only have 10 minutes or so. I hope that gave an introduction to a hospital-based service in London that is trying to do innovative things, that really wants to connect globally with many places. I talked about some of the work that we're doing at a population health level and an integrated health level and around education and training, and would very much welcome any connections. Thank you very much indeed.
Agradecemos al doctor
We
Cross
thank Dr. Cross for his extraordinary and important presentation, and we invite him to remain in the room. At the end, we will have a dialogue based on the questions left by the participant. Thank you very much, Dr. Cross. We now extend a warm welcome to Dr. Paul Dagmore and NHS
Thank you very much.
Trust. Go ahead, Dr. Dagmore.
I will just get my presentation ready. Okay, good morning or buenos dias. It's very pleasing to be here. Thank you very much for the invitation to come and speak to you. I'm going to say a little bit about the NHS Trust that I work for, the Tavistock and Portman, and I'm going to talk specifically about a particular aspect of our work, which is in relation to the treatment of trauma. So it's really pleasing to be here and to hear of some of the context that you're experiencing in Peru and beyond. Many of those issues, as Sean said, are very similar to the issues that we're facing here in the UK as well. So I work for the Tavistock and Portman, which is a small specialist mental health trust. So it's not a big hospital. It is a small specialist mental health clinic. So we only provide outpatient services. We were established in 1920. So we celebrated our centenary just a few years ago. And over the last 100 years or so, we have developed a range of clinical services, all designed to meet the needs and treat patients with a range of mental health issues, mental disorders, or factors affecting their emotional well-being. As well as providing services to patients, we have also, over that time, developed a knowledge base that we think is really important in the effective treatment of patients, and therefore we have developed a range of educational and training programs so that we're able to share our experience of working clinically with patients to the wider workforce within the UK, but also beyond, as far as China, South America, and many countries in Europe. So we treat around 11,000 patients a year, and we have around 5,000 students enrolled on our courses from around the world, some of whom come and study with us in London and others who study with us online. And we provide education and training programs from postgraduate diploma and certificate level up to master's and research degrees in a range of mental health and related subjects, psychology, social work, psychoanalytic psychotherapy, family and systemic psychotherapy, nursing, and psychiatry, as well as programs in leadership and management and consultation. We also have an active research profile where we partner with a range of very prestigious universities in the UK and also beyond Europe. So we were established in 1920, and since then we've been at the forefront of developing innovative specialist mental health care through the provision of clinical services, education, and research. And we are well known and have been the home of some of the most important concepts that have developed in the last 100 years in relation to talking and relational therapies. As I said, we are one of the largest providers of mental health education and training in the UK, but also reaching countries around the world as well. In relation to our clinical services, these include a therapeutic school for children who've been repeatedly excluded from mainstream education, or for reasons to do with their mental ill health, they're not able to access mainstream education, and they come to our therapeutic unit. We also have a family drug and alcohol court, which we were instrumental in establishing, the aim being to provide better outcomes for children who are at risk of harm due to parental or substance misuse. We provide particular services for looked after children to meet their emotional, psychological needs. And we also offer specialist therapeutic support for adults and children who experience difficulties relating to involvement in delinquent, criminal, or violent behaviour. So we were established just after the First World War, and initially we were set up to provide services for soldiers returning to the UK from the First World War, experiencing what was then termed shell shock, which we would now refer to as post-traumatic stress disorder. And we developed effective ways of treating these patients, these soldiers, largely using talking therapies. And a fundamental principle at the Tavistock has been to seek effective alternatives to hospitalisation and institutionalisation, treating people in their community and treating people across their lifespan. So working with babies, families, adolescents, up to older adults. And we have proudly been a part of the National Health Service since it was established in the UK in 1948. Part of our legacy includes some of our former clinicians. I'm sure many of you will be familiar with the man on the screen, John Bowlby, who was the architect of attachment theory, and whilst working at the Tavistock wrote his very well-known trilogy on attachment, separation, and loss. And his attachment theory to this day is still fundamentally important in childcare policy and practice in the UK and beyond, and arguably one of the most influential psychoanalysts of all time. So, as I said, I'm going to talk particularly about trauma, which was very much central to our establishment back in 1920 and has been an area in which we've developed our practice in the last 100 years. So we very much adopt a trauma-informed approach to the provision of all our services. And the reason for that is, as this slide outlines, trauma is pervasive, affecting many, many people who come through our doors. And the link between trauma and mental health and mental ill health is incredibly strong. The impact of trauma is very broad, touching many life domains, and is often deep, life-shaping and long-lasting. Violent trauma can often be self-perpetuating, and trauma is insidious, and in particular can have even more of an impact on society's most vulnerable. It affects the way in which people also can approach potentially helpful relationships, including the very relationships that they are accessing to seek support and treatment for their trauma. So having a good understanding of the impact that trauma has on the dynamics in relationships is really important to successful treatment of the trauma. Trauma often occurs in the service context itself, and if we think back to the pandemic and the impact on doctors and nurses treating patients, we can really see how trauma has the capacity to take place within our organisations, within healthcare systems. And as I said, it affects staff members as well as patients. So our approach to trauma is very much, as I said, using a trauma-informed approach, in which case we see that trauma is often chronic, is repeated, and affects fundamental aspects of a person's thinking and their behaviour. Although the link between symptoms and trauma is not always obvious to individuals, to their families, or even to healthcare professionals. In a trauma-informed approach, the patient is seen as a whole individual, and we look at them in their wider context, focusing on trying to understand them as well as their symptoms and their survival and coping mechanisms. And our services aim to promote growth and resilience. They're very much strength-based and are able to flex in order to adapt to the needs of the patient who is experiencing or has experienced trauma. And the relationship is open and collaborative, where patients are given choice. In this way, trust over time is earned, and we also acknowledge that the patient has wisdom to bring to the relationship as much as the professional. So thinking about how our understanding of trauma fits with the way that we deliver services, we very much think about the environment that we're providing to patients within the clinic, the systems that we operate within, thinking about how we work with each other within the organisation, as well as professionals outside of the organisation, the processes that we ask patients to access and go through, how are they delivered in a way that's meaningful and most helpful for our patients. Very much thinking of all of the relationships that our patients have with the entire workforce with whom they come into contact, not just the therapist or the clinician, but the administrators and everybody else in the hospital setting. Thinking about language and how we talk about things, particularly at the beginning, before patients walk through our door, how they understand what we do, what we're seeking to do, trying to make sure that everything is clear. including our formulation. So being able to talk to patients about the ways in which we're understanding their presentation and how that's going to inform what we propose to offer in terms of a treatment package. Thinking about how patients can access our treatment, how are we effectively reaching out into all the different communities with whom we work. Thinking about those groups of people or communities who maybe don't traditionally access talking therapies. How do we go out there and make our services as available as we can to as wide a group of people as possible? Thinking about the effectiveness of our treatment, ensuring that we are reviewing the treatment, we are reviewing the goals, we are evaluating our work in order to understand whether it's being effective, ensuring that we are seeking to take on board the feedback of patients throughout the treatment, and that we're able to change course if that's what's required. And thinking about the organisation as a whole and how we work with other organisations and the wider community. So why might you or us become trauma informed? It's important to avoid causing further harm to patients or triggering any existing harm that they may have. It also, we think, encourages engagement. So recognising how trauma might affect somebody's capacity, ability, or willingness to engage with us is really important in helping ensure that we are doing everything that we can to make our services as accessible and open to people. To be more effective by recognising the role that trauma plays in the presenting issues in all of its complex ways. And to promote well-being by creating a safe context so that patients are able to heal and grow is really fundamental to what we do. So I'm going to talk a little bit about one of our dedicated trauma services, and this was established in our organisation back in 1989. And it uses a psychoanalytic trauma-informed approach. I'll say a bit more about that. And last year, it won the Innovative Excellence Award from the British Psychoanalytic Council. And our lead clinician in the trauma service, Joe Stubley, received a fellowship from the Royal College of Psychiatrists, which we're really pleased about. We're very proud of our trauma service and its work. So the trauma service is an outpatient psychotherapy service. As I said, it has used a psychoanalytic understanding of trauma to develop its way of working. And from that, we have developed a flexible, adapted model of therapeutic interventions for complex post-traumatic stress disorder. And this model incorporates the potential use of other modalities of treatment, and it recognises the important findings from a neurobiological understanding of trauma, including the impact that trauma has on memory. And the model also keeps the importance of the body in trauma therapy very much in mind. As this is an NHS service, a publicly funded service, demand always exceeds supply, and resources are increasingly scarce, particularly in this age of austerity. We're really pleased that the NHS England has recently given us additional funding to extend our services so that we can reach more patients. But even within that, the length and intensity of treatment is a really important issue, and it requires us to be creative in developing the service, where there is a need to offer something substantial in many cases, and that can often mean quite lengthy interventions and treatment packages. Since the unit was established, there's been a gradual change in the kinds of referrals that we've received. So we're now receiving many more traumatized asylum seekers and refugees coming through our doors, including people that have been victims of torture. And their experiences are usually of a chronic, repetitive, and sustained nature. We've also had referred to as veterans from the armed forces who've often had significant trauma prior to the traumas or the experiences they've had at war. And increasingly, we're now being referred patients who have experienced significant childhood trauma, often with a more recent adult trauma as their precipitant for the referral. And in the last few years, many of these referrals have been for historical child sexual abuse. So the service adopts a phased approach to treatment, which has 3 dimensions or phases to it. The first is therapeutic engagement. The second is remembrance and mourning. And the third is therapeutic endings and reconnection. And I'll come on to say a bit more about that. So this just gives a sense of the relationship and the intervention. Central to any aspect of the intervention is the therapeutic relationship, whether that's with the lead clinician or any of the other clinicians that might be involved in providing care to our patients. So the first phase is the stabilization phase, which begins with an introductory meeting with the patient, where they are introduced to the service and the types of support that's available, including a psychoeducation group, a peer support group that they can drop into, a trauma lending library where they can access a range of resources that provide support and help in relation to specific aspects of trauma and trauma care. The second phase is the actual therapy itself. And following an extended consultation, which lasts for 4 sessions, patients are then referred to a range of different types of intervention. And you can see a number of those involve different groups. And the use of group interventions is specifically designed because we know that it allows the possibility of trust to be built between the patient and clinicians, but also other patients. This includes a 6-week trauma psychoeducation group, a 1-year trauma art therapy group, and a trauma yoga group, based on research evidence that shows that yoga improves patients' capacities to make use of talking therapy and to be in touch with their bodies and bodily states, which is really important in trauma recovery. And then the final phase is the reintegration phase. And this notion of reintegration is really important in the work. And that's about finding a way to reconnect with the world after the trauma that acknowledges what's happened, but also allows life to continue. And in this phase, we very much work with the patient in their local community so that they're able to re-establish themselves in the community. I'm now just going to say a few things about our education and training, which has developed over time. And because we've been working with trauma for a long time, we have lots of interest from organisations and individuals asking if we can provide training to them on the ways that we treat trauma. So we've developed over time a number of different types of education and training programmes, as you can see on this slide. And this includes very short introductory courses that introduce the idea of trauma, self-care and building resilience. And these are 5-hour self-directed programs on our online digital platform. So they can be accessed by anybody anywhere in the world. We also have online courses. So we have a 1 or 2 day course on trauma-informed care, which is about some of the things I've just spoken about and helping people apply that to their everyday practice. and that's a live online course using the Zoom platform. And that can be delivered to organizations, to a whole workforce, but we also offer places that people can access at our organization. And then we have some more in-depth courses, an external lecture series delivered by expert clinicians from our trauma service. They're available and they can be accessed via Zoom as well. We've just launched a 2-year certificate in complex trauma, introducing people to the way in which we work. And this is for qualified psychotherapists. And then we also, at the request of many people and organizations, we've now developed a 12-week online learning program on our digital learning platform. I'm just going to say a little bit about that course, just to give you a sense of what that looks like. So this is its title. And it runs multiple times throughout the year. It takes place over a 12-week period with up to 120 hours of learning. And it's taught by experienced clinicians, usually psychologists, who work with us in our organization. It's largely self-directed, so learners access the program online and study at their own pace via the learning platform. But it also has some 1-hour virtual seminar groups that learners can access as well. And it has a whole range of other media. There's an option for a written assignment. You can find out more information on our website. And just very briefly, because I know we're short on time, these are the aims of the course. So it's very much about broadening people's understanding of trauma, looking at its impact, increasing people's awareness so that they're able to adapt their practice or even their service accordingly, and develop trauma-informed cultures and services. So, as I said, it can be studied at a time and pace of students' choice, with self-directed study and some additional seminars. And there's also a communication process through an online discussion forum. I won't go through all of this because I know we're short on time. It just gives an idea of course content. All of this information is available on our website. And I will just give a very quick summary of what the course looks like. So it has a simple and clear layout for each part of the course so that it's easy to access. With the same weekly structure, including videos, quizzes, discussion boards, reflective activities, and tasks. Interactive lectures that include videos, audios, graphics, diagrams, statistics, etc., which guide students through each of the topics studied. Assessment is available for those that want to. And I will stop there. If you have any questions or would like to contact me directly, if you click on the QR code, it will give you my contact details, or you can look at our website and find out more information. I'll stop there. Thank you.
Le agradecemos al doctor Gamón.
We thank Dr. Dagmore for his magnificent presentation, and Dr. Crosses and Dagmore's presentation have highlighted the importance of strengthening the skills and to refer on a timely basis, as well as the importance of strengthening the capabilities for prevention and healthcare in general. Regarding trauma, the importance of tackling it at any stage of the life course has been highlighted considering what it can generate for the lives of people. Something that we need to highlight is the importance of engaging the patient and treating them comprehensively and giving him an active participation during the treatment, forgetting about the treatment that we normally have in having a paternalistic attitude. In this case, for treatment of trauma, as Dr. Dagmore highlighted, the participation, information, and knowledge of the person about the process they are living is very important as well. So, and both in his relationship with the therapist and to generate trust, which is very important throughout the process with the therapist and with other people who are sharing the same. We would like to thank you for your participation, Dr. Dagmore. Magnificent and important presentation. Please stay in the room, and we will continue now giving the floor to our dear and welcome Vice Minister, Dr. Peña. The floor is yours. Well, thank you. Thank you very much. Thank you very much, Dr. Calle, the executive of the Andean Health Organization and one of the agencies which has a voluntary agenda, including these webinars, which not only allow us to deal these important matters with the foreign experts, but also establish links that will generate collaboration work, especially with the countries having a long experience. I would like to say hi on behalf of Dr. Vasquez. And first of all, I would like to thank and congratulate the organizers of this event, because mental health, it's been fully proved that it is a fundamental aspect that we need to safeguard everywhere in the world. In the last studies carried out by the Ministry of Health, they give evidence as to how mental health impacts the well-being of the people, especially here in a country that is dragging an unfortunate story of a history of conflicts, unfortunate conflicts and extreme weather events, and events that have a direct effect on mental health and trauma as well, as has been discussed, which is then translated into health problems. In our country, in the past 15 years, to be more precise, since 2015, we've been working on a reform on mental health, thus changing the perspective of a hospital-related view that's always looking to institutionalize those patients suffering from these problems without having the vision of prevention and promoting health. And this refocusing of this problem has been started with a community territorial approach based on social determinants, with a comprehensive approach where prevention is taken as the forefront of this approach. We've been having very important breakthroughs with the implementation of mental health centers in the community. We've had an important progress made in the past years on this regard, and we've also worked very extensively in providing services that will take mental health services closer to the population from the first care level, even with services being given to mental health patients who are in the streets in unfavorable situations. So under this perspective, we could mention many of the efforts that have been taken in Peru to improve the way that mental health is tackled. But once again, having the expertise, having the experience of interventions that you've been implementing and that convey scientific evidence to studying mental health phenomena to practice, the way that this is implemented in the field is something which is actually very valuable to us. And this opportunity, I'm sure that the representatives of the Ministry of Health, which are joining this call, who I'm sure will have the opportunity of expressing some specific questions or comments about the work that we've been developing in Peru, we need to use this opportunity to leverage on those tools that you have in terms of training, but also we will enable opportunities to share information and develop collaborative studies in the implementation of these services, building on your experience. I'm sure, and also the purpose of my office and the minister's work is to be open and to always establish bridges and links with long-standing institutions, high-quality institutions as yours. And definitely, I think that this is the first step. I understand that Horas Konu has been having a lot of experience on mental health issues as well as other subject matters, which to us are very important in our country. But once again, this is our commitment to take the most of this opportunity to keep on working together and provide this benefit to the population, which is most needed. Thank you very much once again. Thank you very much for your kind words. And now I would like to introduce Dr. Tim Barker, CEO of KUTH, who is welcome. And now you have the floor, Dr. Barker.
Good afternoon, everyone. And before I start, just want to say thanks and gratitude to our translators who are connecting us today and doing such an incredible job keeping up with everything. So today, this afternoon, I'm going to talk about how the solution for tackling mental health care for Generation Z, ages 10 to 25, may already be with us in our hands. So I'll tell you about the journey that we've been on with KUTH in the UK and the work that we're doing in California to support the diverse population and their growing needs for mental health support. As has been well documented on today's call, there is a growing...
Disculpa, se estaba escuchando doble. Sí,
Ya está solucionado.
Just check you can hear me okay?
Prosigue, Vanessa.
There is a growing crisis globally in mental health, nowhere more so than in the young generation, where demand is growing double-digit every year. On the right-hand side, this graph shows in the US, over the last decade, we've seen a longitudinal growth year on year in individuals seriously considering suicide. And as we all know, 75% of lifetime mental health problems are established by age 24. If you're to have a strategy for tackling mental health, you need a strategy to provide support rapidly and effectively for those younger years. KUTH is not as old as the Tavistock. We were formed in 2001, so the very early days of the internet, to answer the question, how could the ubiquity of internet access help transform youth mental health care? And we focus on three key pillars. Firstly, with the internet, we can grow access, we can remove barriers, and we can help reduce stigma in seeking help. To grow access, you also need to embed and work alongside and within communities. So that means putting teams out in communities that can build trust and build awareness of the service. You also need to take, and we've heard this earlier in today's session, a person-centric, not a condition-centric approach. To reach people early, we need to demedicalize the topic of mental health, and we need to recognize that there isn't a one-size-fits-all for everyone. And as we heard from our first speaker, we need to tackle this as a population health service. So providing a digital front door where you could connect individuals into other services and specialist care, such as trauma-informed therapy. And you can provide insights to identify the trends of mental health within your population. That's where we started, and at a very high level, what we offer is an integrated service that provides self-therapy, so educational content, through to tools that might help you in the moment, box breathing to manage your anxiety. To get advice, an individual might then also get support from the community, a thriving peer support community where obviously peer support is recognized as an incredibly therapeutic thing. You're not alone. There's others that have been through similar challenges and showing how they got through those. And finally, to provide direct access to professional support. So in the service we operate in the UK and in the US, we've delivered nearly 2 million hours of professional support, and we can do that through messaging-based or video-based or telephone-based channels. Obviously, for many younger people, they live in messaging apps, so that's convenient, keeps things confidential as well. You can't, of course, tackle this without then building a body of evidence that demonstrates the efficacy of that. So, and on the journey that we've been on, we've discovered that in building a solution for this that really focuses on the wants and needs of individuals, it doesn't always match with the research body that is available for evidence. A great example of this is a large number of individuals we might see infrequently or once. There are no single session therapy measures out there to demonstrate the efficiency and efficacy of that. So we've invented them over many years to demonstrate that brief therapeutic interventions can deliver effective care and not just long-running structured support. The journey I want to talk to you about is one where Kooth, over those 20 years, has become the largest access provider for young people, with more than 60% of the population of 10 to 25-year-olds having free access through their NHS. I want to talk a bit about the project that we're working on in California. We were fortunate enough to be awarded a contract with the state of California last year with an incredible, ambitious plan, which is to transform access to mental health care for children and young people by providing them with free access to resources, tools, and professional support funded by the state. Probably the largest single transformative mental health program in the world. There are perhaps 4 key principles, and we'll touch on a couple of these in the session. If we're going to tackle and solve this problem with young people, they need a seat at the table. You need to design services with and alongside, not just for youth. And in doing so, you can deliver an open digital front door that is culturally sensitive to support the diverse needs of a population. In doing that, you want to be assured that you can provide effective early support to prevent the escalation of mental health problems and develop lifelong skills to help build resilience. And finally, although you may build it, no one will come unless you are engaging to build awareness, both online and within communities, to help build that awareness and trust. I want to spend most of the time remaining just to talk about the topic of co-production, because if we're going to demedicalize and destigmatize support, the exam question to answer is, how can we deliver a culturally relevant digital mental health platform that is as engaging as a consumer app, because people are using this outside of school, but as effective as a clinical service. So that means embedding safety and quality to enable you to scale this to support a whole population. So some of the things we've done on that journey. The first thing is to go back to some of the fundamentals of the change that we are looking to make in the population. Of course, providing them with rapid access to support has a benefit in and of itself. But if we are to think about moving upstream to prevent poor mental health, what better than to help people on a journey to build their resilience, or in psychological flexibility, as we probably should refer to it. So the things that we need, the ingredients, the support we need in our life to help build that resilience, to help us deal increasingly with an uncertain and unpredictable future. Some of the work that we did over the last year was to engage and co-design, both with our clinical teams, our product teams, and the voice of young people across the diversity of California and the US, to put that design at the heart of our service. So a small example here of a white noise generator that one of our youth advisory board members found so helpful to help them in the moment. And so what's fascinating is when you develop a service alongside young people, you're building something that you're expecting to have high adoption, but also to take people on that journey to psychological flexibility. So some examples of what this looks like in real concrete terms. Autonomy means that exploring the content and the topic of anxiety doesn't feel like homework. You're exploring a universe, a constellation of content freely that will be engaging, clinically effective, and relatable to you. In terms of being relatedness, you want to feel that this is a service that is relevant and relatable to you. So having content that matches where you can see yourself in it, vertical videos that are relatable from people just like you, but done in a way that will offering great clinical advice and support on the journey that people are on. And finally, if you were to take a coaching approach to helping people make change in their lives, to live the lives they want, you need to provide professional support and remove barriers to that. So, for example, the idea in California that you can access a coach of choice based on your wants and needs to help you develop as an individual to cope with challenges in the future. This is the journey that we're on. Here, for example, is some promotional material. Obviously, we are supporting a large Hispanic population in California. I should say that our service is available in 19 languages, though. So we are there to support, as a population health service, the diversity of the population, underserved populations, and marginalized populations. What we expect to see from our experience in the UK is that we can, by providing early help, reduce the demand for acute mental health treatment. Of course, we're always going to need an integrated approach that provides support to individuals, whether it's trauma care that may be needed or early psychosis support, as we've heard earlier. But from what we see in our own data, 60% of people, when you can reach them early, get the support they need from the content and the community. 35 will get professional support, but it might be infrequently or drop-in support. 5% will be on that journey for more structured, intensive counselling. But by reaching people early, we can reduce both the demand and the cost of healthcare by providing that early preventative support and helping them build skills for life. Finally, where are we going next? Well, in California, our service rolled out to the entire state on January 1st. So we are focused on growing awareness and usage with underserved and marginalized populations. We are also recognize that this is not a digital island that we're building. So we are a single point of access into other services. We have a directory of every service available, whether that be a clinical service or for individuals really struggling with loneliness, a social prescribing service, perhaps connecting them to a local community group where they could get involved to reduce their isolation. And importantly, to develop health economic outcomes that demonstrate not only the great that we can do by reaching people early to improve their lives, but also the health economic cost savings to healthcare systems so we can reduce the overall demand, because as we know, there are always challenges in building a workforce to deal with the ever-growing demand. Our ambition, based on our very humble beginnings in the UK over 20 years ago, and building on the work that we're doing in the UK and in the US, is to license this platform to healthcare operators in international markets so you can support your local population with your own staff to provide culturally relevant, effective care for an entire population. Thank you for listening, and I'll pass it back now for any questions.
Sí, muchísimas gracias, doctor
Yeah,
Barker.
thank you very much, Dr. Barker. Very interesting presentation. Definitely everything that we discussed in terms of reaching the population, supporting the population will contribute to decrease the demand that we have for mental health services. Well, we're just starting with a chatbot. We hope that it will be available soon, and we hope that the people working with vulnerable populations will take over. And this presentation that you've given us is very tempting, and I think that it could be very well applied for the youth of the Andean region. Now we will continue this interesting webinar welcoming Dr. Chris Butler, Director of the Impact Dementia Program. Dr. Butler is also a clinical senior lecturer in dementia research at Imperial College in London. And we would like to thank Dr. Sofia Cuba from the Impact Dementia Project. Dr. Chris Butler, he comes from the Imperial College of London, and Dr. Cuba comes from the Cayetano Heredia University in Peru. Both are working in the same project, and they will present this project to all of us. The floor is yours now.
Voy a hacer la presentación y
I
tal vez
will give this presentation, and maybe Chris will add something in the end. Good afternoon, everyone. Thank you very much for the invitation. It will be important to tell you why we're here. This is the Impact Salud program, which is looking for innovation in digital health for the treatment of dementia and comorbidities, which emphasis very likely will be explained later on throughout the presentation. We are here because there's many people like Martha, who lives in Tumbes, 77 years of age, and she's been forgetful for a lot of time, and this is increasing. And she's deaf as well, and she really doesn't know what's going on with her because she does not have a diagnosis. Her daughter, Rosita, does not know what to do best to look after her mother, and she's depressed. What I'm mentioning here is something which is very common in many cities of our country. I'm a primary care physician, a family doctor, and knowing beyond the disease, knowing people beyond their disease is something that we try to do every day, and we see them beyond their diagnosis, either being deaf or having dementia, and we have to consider how this impacts their families. Dementia is actually a global priority. People with dementia have twice as much comorbidities than those without dementia. And in Latin America, it is expected that dementia increases 205% between 2019 and 2050. This is something different from what's going on in developed countries where the prevalence of dementia is going down, but in Latin America, it's going up. In Peru, dementia is the second disease in creating more losses of healthy years in people over 60. And we wanted to present our project, Impact Salud. This is a project with funding from the NIHR, having different universities of the UK, led by Imperial College of London. And also we have the University of Oxford, the University of Edinburgh, and Cardiff University in collaboration with Cayetano Heredia University. Well, the goal of our project is to strengthen the health service through sustainable, integrated, human-centered innovations developed in the community and facilitated by technology. We strive to work with people with dementia and their caretakers to work on the health system as well. And we have some investigation and research lines that we will present. We will be present in 4 cities, Tumbe, Lima, Quito, San Huancayo. And one part of this is to carry out a study on the preparation of the health system and having a guideline to work with patients with dementia and their caregivers. Peru is transitioning to having integrated health networks, not only in name and regulations, but actual integrated networks. And we believe that this could be an important contribution for this purpose. The second space where we will work at is in developing a management tool in the community, a mobile diagnosis system for screening of dementia. We believe that the participation of the community is important in screening, and it should be an easy-to-use tool which does not necessarily need to go through a physician. The third pillar or component is the community intervention that we would like to apply. We have this task of adapting an experience supporting by technology care ecosystem. This comes from the US, but in the British system, they've been using a healthcare navigator for primary care, for dementia and other problems. And in many other countries, this is being supported by the system. In our country, we have a long-standing tradition of community agents, health agents, and we believe that having a navigator or a nurse technician could very well become this navigator that will be applying this approach that people with dementia need. Dementia is a very complex problem, as you know, and it is not managed only with drugs. And this is one of the examples of the problems that we might think that we need to tackle differently, with accompaniment and not with a pretense of curation. And this is a very complex reality for all citizens in Peru, but especially for the people who are more prone to having these problems, like those people with dementia and their families. As part of our project, we will identify the economic costs of dementia and know the economic burden for people with dementia and their families, as well as the states. As I mentioned, these 4 components go hand in hand or go in line with the awareness of dementia. There's a mental health reform going on in the country for some years now, with very important results so far. We still need to do more, I think, but we believe that this project could be a large-scale intervention to improve the quality of life of people with dementia and their caregivers. We will try to implement a community screening tool that we hope will be good for the country, that could be adapted and adopted by the public system. And we will try to help the country in the National Dementia Plan, which is already built. But now I think that is following some steps at the Ministry of Health for its approval. Remember that the WHO promotes having national dementia plans in all of the countries, and Peru is one of these countries that does not have it yet. We hope that we could push this forward soon, and maybe by the end of year, we will have our national dementia plan. And we think that if we are successful, we could be a benchmark for other Latin American countries. And we've not added this in the presentation, but a very important project, important component is what's going on with the people with dementia, how they live, why this is also a problem that should be dealt with in the health system, and why the relatives should receive support. We think that our project will generate an approach as a model to look for complex problems to introduce improvements in the health system. When we are person-centered, I think that this could be applied also to other complexities. And not always this will be something that we deal with in the hospitals, but also we have the technology as an ally. So I've tried to move fast because we are lagging behind. And this is a presentation of our project, Impact Salud. We are working with Chris, and we already have some publications, and you can follow us on our social media to gather more information about the project. Thank you very much.
Perhaps just a few words. Just a few words, because Sofia has explained things very well. Just to say that it is a privilege and pleasure to work with my colleagues from Cayetano Heredia University. And I know that the academic world, the public health world in the UK is very well dedicated to the global vision to walk on this path in terms of research and promotion these cause of dementia in a very collaborative manner, and we are learning very much from our colleagues in Peru. I know that the dementia world, it's almost going to go through major changes and advances at this moment. We have new treatments and new ways of diagnosing dementia that are going to change the entire profile of the diagnosis and treatment of dementia in coming years. And the countries in Europe and North America, we are thinking, how are we going to approach this? Because there's so many patients. And these new treatments and new ways of diagnosing this condition are going to cost a lot and going to need an enormous reorganization of our health system. And I think that in Latin American countries, if we have to start thinking that we can no longer forget this, ignore this issue, because we don't see these patients. They're hiding at their homes many times due to the lack to stigma and lack of awareness. And our impact project has the vision of putting the patient at the center, and as many had said, not only focus on one single condition, but in the family environment and the other comorbidities. It is very important to try to change the way how we approach this dimension of dementia. I'm not explaining myself quite well in Spanish, but we're very thankful at Impact program to the goodwill of our patients and our collaborators in the project, and with a lot of hope for coming years. And we're very thankful to be participating in this meeting with all of you. Thank you so much. We thank Dr. Cuba and Dr. Butler for this excellent presentation. We should highlight that Dr. Butler has a very good Spanish. We were able to understand him very well. So we invite you to stay in the room and to participate in the dialogue based on the questions left by the participants of this webinar. Now we're going to thank to all those who are with us, especially the officials from the Ministry of Health and the academic institutions, social institutions, and public and private institutions of Argentina, Belize, Bolivia, Brazil, Chile, Colombia, Cuba, Ecuador, El Salvador, Spain, US, Guatemala, Mexico, Nicaragua, Paraguay, Panama, Peru, Dominican Republic, UK, Uruguay, and Venezuela. Thank you so much for being with us and participating in our webinars. Now we're going to start the comments from the conferences that have been shared. And for that, we welcome Dr. Yuri Cutipe, who's advisor to the Ministerial Office and former Director of Mental Health of the Ministry of Health of Peru. Go ahead, dear Dr. Cutipe. Thank you very much. Group of nations. The invitation as a Minister of Health and participate. It's a very interesting meeting and the experts for the mental health services. The experience of the services provided by the hospital, additional services provided, that although it is true has been modified in time, but it comes from the time that we understood this differently. Then we've been able also to receive the explanation of the work being done by Tavistock, this ambulant outpatient treatment so well known in the psychiatric and psychological world from the UK. And we've been able to identify the characteristics of a different perspective, a different way of dealing with psychic suffering, conditions. It has been very interesting to hear how they put as background so that the services can be adapted in understanding the suffering in terms of the generation through trauma that is a constant in their life, unfortunately. But if we don't understand it, when we approach or relate with a person, and especially this is a mental health service, perhaps the service itself is going to be contribute to increased trauma or its complications. On the other hand, I also thought that it was very important that in the explanation of Dr. Tavistock, of Dr. Dagmore, the perspective of these packages of care that we call the toolbox, given the high variability with the symptoms and the psychic suffering that a person may have, even when they have shared the same traumatic experience. And that is due to a state service that is very important, because it reminds me a previous session that we had with the National Health Services from the UK, where they were explaining us that in mental health there's a type of financing that is quite specific compared to the rest of financing of the health services, and that financing is by episodes of psychic complaints in order to organize symptoms, not due to diagnosis or specific packages that the rest of health problems may allow to have some standardization due to the high variability of the symptoms or the psychic complaints that trauma brings, or other mental health issues or other injuries to mental health. So I know that that aspect, we have seen presentations of colleagues that work on those services, but as a Ministry of Health, we would be interested to know what happens from the perspective of the service and the type of financing that they currently receive from the British government. If you think that this model of financing by episodes is a more appropriate model than financing by diagnostic packages or diagnosis, or if you think that there's another important way or more efficient, perhaps, to treat the diversity of problems. On the other hand, and I think in this presentation by Dr. Dagmore, we could put the issue of the high variability in this treatment package, and we were able to see something specific that called my attention, that there are two components that we still in the process of the implementation of the reform of mental health services in our country. We are under the process of implementation, which is to consider the social prescriptions and the group effort and component that nowadays is receive more value throughout the world, and we start to see the emergence of scientific evidence regards the impact of the group effort or the multifamily groups and self-aid groups in order to achieve the efficacy of treatments or improve the efficacy of those treatments. On the other hand, I also would like to comment what was mentioned by Chris Butler with regards to the implementation of the virtual care, or due to the large number of instruments that we have through the apps or web page with several resources and self-applied resources to the point of having resources with connection with the community active services. So I believe that that is an important challenge. We believe that this experience that is being used in California could be adapted to our reality, although that we know that in California there is community mental health services that by having this type of devices may strengthen the impact of services, and of course it can strengthen the possibility of having more coverage of it. But it is precisely, I think that this needs to be demonstrated, and it's important to try to see what is the impact in reducing the gap in care and to reduce the demand for mental health, and at the same time have evidence about the impact in the well-being of the person, which is the most important at the end. Right of a service, if it's expensive or not, first of all, it has to be effective. And in that regard, and I think this is something that we can discuss more specifically, if have you been linking it with the use of artificial intelligence? And I'm sure you've done, because this is something that's been incorporated in what we call artificial intelligence can be of help. However, there is something that I also would like to mention that may be responded with the idea of focalizing in young population, in adolescents, in young persons, and perhaps children and their parents. The use itself of this internet channel in the different expressions by the population for their care in mental health. In 2022, in the conference that we participated in the UK National Health, we were told that they have observed a drop in the use of virtual channels for the care of mental health that, of course, had a very high use in the year 2020. And that had been reduced to 10% of the demand, but they had maintained these digital or virtual services because they consider that it was the right of the person that would like to receive care in this manner, which is a very interesting concept, because we start to see that virtual care is a component of the right to health. So I think that there we have something to take into consideration. Perhaps this 10% in the general population is 40 or 50% in the young population. But I think that it is very important to have that information at hand so we can also use it for the development of this type of interventions. In general, I believe that this is a very important contact because it also generates to us the possibilities mentioned by the Vice Ministry of Public Health with regards to the possibility of relate and develop better competences or strengthen the competences of our mental health services to care for the people who have psychic suffering, and also in terms of improving the channels of care to have more diversity of care channels and that they have proven to be effective. And to conclude, two questions in relation strategies that have been implemented in the UK, I think 2 decades, such as the well-being consultations at the first level of care to learn about its impact and the population indicators, mental health issues. This is a strategy that has been quite strong, even in financial terms, in improving access to mental health services. And also to know what about your projects of deinstitutionalization and implementing a policy of recovering people who have psychosocial disability, which is of severe characteristics or high dependency characteristics. I have these 2 questions for you. I'm sure we're going to have a space to discuss about. Thank you so much.
We would like to thank Dr. Yuri Kutipe for his presentation. We would like to ask all the speakers to start their cameras to begin our dialogue now. As a first step in this dialogue, we would like to invite all of the people who are with us to give comments or ask questions. But I would like to highlight that Dr. Kutipe has ended up by asking some questions that will remain open for all of the speakers to answer whenever they think suitable. So now let's get the dialogue started. Yes, Dr. Kutipe, go ahead. Now, since everyone is in silence, I would like to mention that especially the work that we've been doing by Impact Salud with the leadership by Chris. He was born in Arequipa. And Arequipans are born wherever they want to be born. And Sofia, who's also Peruvian, I wanted to recognize the hard work you've been doing because it's very important what you've mentioned about Soluna, and it's like bringing this to our national reality and see how technologies which are really effective to look after mental health might be implemented with Alzheimer's or dementia, but we have to take into account our social reality, our cultural reality, being catalysts of the resources that we have in Latin America. We know that we've been keeping a lot of social capital in the society, and we have to consider the community support networks, family networks. This is something that we have to bear in mind even more so in mental health, because this is a social determining factor and a cultural determining factor. Thank you very much. I'm sure that we will have another meeting to know about the progress made through Impact Salud. Thank you. Thank you very much, Dr. Kutipe. And once again, we would like to invite our speakers to answer the questions that Dr. Kutipe has asked. In any order, if you would like to start.
I'm happy to make a start in relation to the question about finances and provision of access to services, which is an issue that we constantly grapple with within my organisation. I'm sure any other part of the NHS in the UK, where money is always in huge demand and probably inadequate supply. And like in Peru, as was said at the beginning, a very small amount of the budget, the overall budget, is spent on mental health. And within that, an even smaller part spent on child and young people's mental health. As I said at the beginning, our ethos and our practice and our clinical work has always been about providing support and treatment to patients in the community with the intention of avoiding admission to hospital and long-stay institutionalization. And over time, much of our treatment was prefaced on long-term psychotherapy. And over time, that's gone out of fashion because, of course, it's more expensive. And of course, we also have new evidence bases for new and emerging treatments, which we need to constantly be thinking about and implementing into our services. And I think my example of the trauma service was an attempt to illuminate how we have taken a very traditional approach to psychoanalytic psychotherapy in relation to the treatment of trauma. And innovated and created a more flexible, responsive way of working with people with very long-term ingrained chronic and acute mental health issues by developing multimodal approaches to the treatment of trauma, which can combine and include psychotherapy and, where needed, longer-term psychotherapy, but also to accompany that with other dimensions of care that also draw on strong evidence base to treat trauma, like EMDR or yoga, or even more innovative and more recent developments such as our gardening group. So, we are constantly under pressure to offer the shortest treatment possible to treat as many people as possible, as quickly as possible. I think, as Tim said, treating people as early on in presentation is really important and provides a much better cost-benefit approach to the provision of healthcare. And we're often dealing with patients who come to us who probably haven't had that support put in place earlier on. So I think it's a constant issue to grapple with, and I certainly don't think we have got all of the answers. It's something that we're constantly trying to work creatively with to develop different ways of working. But I'll stop there and let other colleagues say things.
It's great to add to everything that Paul has just said. One of the key things for us, we're a large traditional mental health hospital, is recognizing that deinstitutionalization, which has happened in the UK over about a 40-50-year period and was more or less completed about 20 years ago, has been a success, definitely. But the move away from long-term care has not meant moving away from inpatient care. And no matter how hard we might try, the need for safe mental health hospital spaces remains acute. And we're in my emergency department today, and there's just overwhelming need. And so when you start thinking about how a large traditional hospital like ours, together with Paul's institution, which is very close to ours, it can have something to say, can have something to innovate around how we do this differently, it's dissecting out those levels. So the thing that we as mental health practitioners need to be continually lobbying for is not, I think, more and more psychiatrists and more mental health beds. At one level, nice as that might be for my own profession, it's actually understanding that, unlike many other components of many other of my colleagues in medicine, we in mental health need to be influencing Ministry of Housing, Ministry of Transport, Ministry, how and where we get our food and water supply and recreation, how our streets are run, how our communities kind of work. And in itself, that is a sort of building block for all the community action stuff that is so important, because as Tim has demonstrated, getting people to be able to kind of own agency over their own mental health and understand that approach to being able to enhance their own mental resilience and health is the way of preventing people ending up in a hospital like mine. And so it's in our interest at the hospital end of things, the mental illness end of things, to work in conjunction with Paul, with Tim, with the whole of society, I think. And this is the exciting thing about mental health. It isn't just about this disorder, this disease. It's about how do we actually make our entire society work better. When you start thinking about the amount of money across our healthcare budget that goes into traditional mental health care, it's under 10%, which is much higher than many other countries. There are too many countries in the world sort of grappling with sort of 1-2% of healthcare budgets going into mental health. I'm well aware of that. But the way for me to try and enhance that and increase it is to embed it in other components. So the example I gave of starting to get on diabetologists, or cardiologists, or endocrinologists to start thinking about mental health care and for them to become advocates of mental health care. Because, you know, you speak to a diabetologist and you say the best way of being able to prevent morbidity and mortality for your patients with diabetes is not to reach for more and more insulin, but to work out how to give them a healthier diet and how to start thinking about the social determinants that are driving their choices. That is the kind of prevention agenda that I think mental health professionals also need to be engaged in now.
And maybe just to add to your point, Sean, you know, if we started from a position of building a mentally healthier population, certainly individuals will need inpatient support. But with an episodic approach, when they leave that, you know, episodic support, you want to have a community service, or you want to have a service alongside them as well. So I think probably what you're hearing from the three of us is, of course, it's an integrated approach. There is no wrong door to go to get support. So I'm talking from about digital services, but community services could be a point. But I suppose the ideal here is that by the time an individual reaches a healthcare system asking for support, they may have missed 10 or 20 opportunities earlier to provide support, whether that be through the determinants of poor mental health, so maybe housing, food insecurity, or through inability to reach them to reduce the demand for that more acute care. And I think the exciting thing, although every healthcare system is constrained by capital and demand is always outgrowing the amount of resources available, is in these kinds of conditions, that's where innovation happens. Because carrying on the status quo is simply not going to tackle the imbalance of supply and demand. So I think that's why it's so important to almost have an industrial strategy to create a mentally healthier population.
Adelante, por favor,
Yes, Dr. Baker. No, I'm sorry, she says. Dr. Cuba. Yes, maybe add only that it is actually challenging working in a country such as Peru and integrating the healthcare is important as well. We are putting all of our efforts there. An extra challenge for us is that the most vulnerable people have less access to technology, for instance. So sometimes certain developments to increase access might still be a barrier in many places, remote places, because of connectivity issues, age issues. Now, this is something that we also need to work on and turn technology into assistance and not a barrier, and how the mental health development should all include not only the hospitals, but also the first healthcare level should include all of this that we've been discussing. We would like to invite the people in the room. If you have questions or something that you would like to add, please let us know.
Thank you, Dr. Calle, for inviting me to ask a question. First of all, to thank for the organization of this important event. I'm very pleased to hear that the UK is working in everything that they have shared with us. But I'm also pleased because from the Ministry of Health through the Mental Health Office, we're trying to work sharing the guidelines that you have shared with us. This collaborative effort involving all the key stakeholders in this process, starting from the citizen, not even the users with mental health, from the citizen itself, how they include adolescents and young people who are key stakeholders in this process of change, among other aspects that are telling us that we're going through the right track, putting the citizen and the community in the middle with a comprehensive care. My question is, with all this progress that you've made, we have some challenges that we were sharing that we like to ask. How have you dealt with the stigma? We have many difficulties to integrate mental health in the health in general, but also to integrate mental health with other important providers such as education, with the teachers or other sectors in Peru from the Ministry of Women and Vulnerable Populations, which is many times not only the health staff, but the providers of other services that are also important to provide that comprehensive care the person may need, and not only because of the lack of economic or resources, but also has to do with the stigma in the community itself. So that is my question, and thank you for the space. Is how have you improved this issue of stigma? Thank you. Thank you, Doctor.
I'll happily.
Adelante, por favor.
I'll happily
go ahead.
I'll happily open the floor with an answer to it. Well, the first thing to recognise is there is no shortcut to reducing stigma. So this is not I do not have a quick answer for you here, but two things that probably come to mind here. One is schools and educators have and parents obviously have an incredible role to play here. Both in the UK and then I can see in the US, there's been over several years, a real recognition to bring social and emotional learning into the curriculum at school for students, even embedding it not just within a topic of mental health on its own, but embedding it within other school subjects and topics. So there's one element of that, which is destigmatizing it through normalizing it, and schools are a great place to start there. The second part of that is to then destigmatize it through the service design. So, for example, our service is called CUTH. It's not medicalized. We don't start the service by identifying the conditions that you are in. And in our service in the UK, you do not need to identify yourself to seek help. So if you could be in an anonymous space where your phone number, your email address is not available to anyone, through anonymity, you could be your true self. And so there are some things that you can do in service design to destigmatize, to demedicalize, to provide a welcoming space for individuals. And some of these things are obviously advantages that the internet can provide. You can then take people on a journey to open up and take them from an unknown to a known individual so you can provide support to them. So there are I'm sure my colleagues have got some suggestions as well, but there are two things there that come to mind in answering your question.
I would absolutely endorse what Tim's just said, and to add to that, I think something that's worked really well where I'm based in London. The Tavistock is based in a particular borough of London, and we provide all of the child and adolescent mental health provision for that local area, and we have clinicians integrated in every team within social care and in education in early years. So it's about providing support, input, and services in mainstream areas within the community. So not just expecting families to come to a mental health clinic like ours, but being able to provide multidisciplinary wraparound support to them in a whole range of other places in the community. And I think doing that makes it less of a stigma, because families don't even think they're going to a mental health service. They're just going to the places that they often go to. But within those places, there is good quality support available. And I think this has really helped reduce stigma, particularly in some communities that might traditionally be more wary or cautious of accessing mental health support for cultural reasons or for very good reasons of having anxiety about accessing state-supported provision of healthcare.
And just to add to that, I think, that I agree with everything that Tim and Paul has just said, but there's also, it feels like there's very much a significant culture change. And, when you analyze, where that culture change is coming from, it's lots of sort of incremental components that start moving towards a sort of shift where suddenly I think we as a society find ourselves being able to talk about things that we wouldn't previously have talked about. And in doing so, sort of stigma starts to dissolve. And when, for me, I've been practicing now for nearly 25 years as a doctor, and the change over this sort of 25-year period has been enormous. And there's lots of sort of reasons for that. All the stuff that Tim will be seeing now in his work with as the sort of Gen Z generation. There's a chasm of difference between those people who are at the other end of the age spectrum. People will just talk about this. They're literate about it. They will just kind of be happy to engage in it. You see it in our parliamentarians. You see it in our monarch. You see it in the royal family. You see it in actors and pop stars. There's just an amazing ability to be able to sort of talk about this in a way. And I think all of that contributes towards destigmatization. The problem is that within that sort of bundle of stuff that we call mental health, that people will talk much more openly about, we place everything. We place everything from, just sort of slightly having a bad day through to problems with anxiety or social anxiety, all the way through to severe and enduring mental health problems. And so I think we're on a journey to being able to sort of dissect that out a bit. And I do worry that, when people start being much more open about mental health, they mean one end of it rather than the end that I'm dealing with, that sort of 1%, 2%, 3% of the population with significant morbidity associated with it, for which there's still enormous stigma. And the work that this is an ongoing piece of work to be able to advocate and hopefully impact.
Muchas gracias. La doctora Calle está pidiendo.
Thank you. Dr. Calle is requesting the floor. Go ahead. Very enriching comments, just a few comments. I like very much when you talk about racism. Dr. Cross mentioned racism because the issue is not stigma due to mental health, but it's also racism issue. We were precisely in a meeting in San Diego in last March with a group of adolescent health, and one of the priority topics was racism occurring in all our countries. So this is a comment in this regard. The second topic, in trauma itself, it's not easy. Trauma, it's a very complex issue. And I am sure that around the life course, the child that has suffered trauma at that age, this child should be accompanied through the course life, because it's not going to be easy. I would like a comment in that regard, and also relate that with the topic of violence against children. We are having more premature children who survive. We're having more children with congenital malformations that survive. And if there's a special look in terms of trauma for these children, it's been shown that these children are going to undergo more violence than the general population. Now, with regards of COOP, the active participation of young persons and adolescents, without their participation, you can't do anything. But I ask, we are at a time where 5 generations are together. That has never happened before. At this moment, we have great-grandparents, parents, children, grandchildren, and each generation is a world in itself. So my question is, what strategies to arrive to a consensus? Because I'm a baby boomer and not going to think like a millennial or Generation Z. And there we have the issue of professionals who take care of this, because we usually told our young people should take care of young people, which is not that true. Could you please do a comment on that also? And my final comment, I would like to comment more, but we're running out of time. This Ministry of Loneliness. Ministry of Loneliness, the only country that has a Ministry of Loneliness. And I was checking, you are celebrating 4 years of having that ministry. The creation of this ministry, how do you relate it with the issue of mental health? You talk to them? Do you have some separate budget? How does that fit? Because this is not just the UK, but this is worldwide. It's loneliness. And the people who feel more lonely are the younger one, not the elderly, are the youngest one. Thank you very much for your answers.
Thank you. If I can jump in first, just around your first question around racism, because this is something that is incredibly important for my organization and for me personally. In South London, we are one of the most ethnically and socially diverse places on this planet. We have an enormous number of languages spoken and a very large proportion of people from a wide variety of different backgrounds from across Africa, Asia, Latin America, of multiple generations. And we do lots of research into this, and we measure stuff. And for all the talk about mental health being at its core wanting to enable people to flourish, if you fall at the first hurdle of not offering an ability for people to be able to flourish in who they are and their core identity, it's a massive problem. And when you look at the outcome data that we have in London, there are enormous red warning signs, because if you are young and Black, you're more likely, and male, you're more likely to be diagnosed with psychosis. If you're young, Black and male, you're more likely to be detained under the Mental Health Act, which means you end up in forcible acute care. You're also more likely to have injectable depot medication and be restrained rather than oral medication. All these outcomes are associated across dimensions of race and ethnicity. Even away from acute inpatient care, you're much less likely to engage in psychological therapy if you're from any minority ethnic grouping. And you're much even less likely to do so if you are male and from a minority ethnic group. And so all of these together, when we look at the dreadful outcomes, we need to sort of channel back to work out how it is that we, with the best of intentions that individuals may have structural systems within our, not only within our societal structures, but within our healthcare, within our mental health care, and within our ward-based structures. And I'd be absolutely delighted to share some of the work that we're doing around this. Again, it comes down to community-based, it comes down to patient engagement, it comes down to having carers and families involved, it comes down to making sure that co-development and co-design in approach and co-development of education and training for our entire staff, and not just us, but also police and social services and everyone else that we engage with as well. So there's a ton of work in this area, and we publish on it quite a lot, and be very happy to share work if anyone is interested.
I would probably, sorry, Tim, I would just add to that. I would agree with everything that Sean has said, thinking about, again, the link between mental health, racism and stigma. The most likely people to be victims of crime within the UK are young men, young boys, even more likely probably to be Black. They're also more likely to be arrested by the police and stopped and searched, more likely to be charged with an offence and convicted by a court, more likely to receive a custodial sentence, more likely to receive a longer custodial sentence, having been found guilty. So racism is rife in all structures of society, not just in the healthcare system. And we also know that the provision of mental health support is very inadequate in our prison service. So young people going into prison are likely to either their mental health is likely to worsen if they've already got a mental health issue, and mental health rates are high in young people being sentenced to prison, but they're less likely to get treated effectively in prison, and likely to come out even more sick than when they went in. So racism is completely endemic and a real problem across the health and allied sectors, really, and one that we are striving to address, and not as successfully as we need to be. I'm going to stop there because I'm thinking Tim might want to say something about the point you made about loneliness, which is also a really big issue for us.
Yes, yeah, perhaps there's two minor points on racism, and then to talk about loneliness. An approach I'm sure that you're familiar with it, that we adopt at Kooth, is one of targeted universalism. There is no universal base level of service or support that could ever support the diverse population and the needs that were in those. So targeted universalism is really an approach to have a universal goal, but a diversity of implementation strategies. And so what may work for a minority population in one area doesn't necessarily provide a universal solution for all. And maybe the only other point just to touch on, and we'll talk about loneliness next, is a challenge that we have, certainly in the UK, is that the population of practitioners in mental health do not represent the diversity of the population overall. And so in the UK, it's a female-dominated, white-dominated profession. So we need to do more better to bring the diversity of experience from the population into the practitioners that we have. It's certainly a key thing that we're actually doing in California, is we're then working with organizations that can help train individuals to provide this early help, to provide coaching support, and bringing them from a diverse population base. And in fact, that means that individuals, when looking for support, can choose someone that is like them, someone that's gone through similar experiences themselves. To touch on then loneliness, I'm not familiar with specific funding that is going into that, but there is both a key focus and recognition in the UK on social prescribing as part of that. The Samaritans, a non-profit in the UK, is a big champion of really trying to tackle these issues earlier. And look, in the US Surgeon General announced that there was an epidemic of loneliness. And as we know, that can be the start of a journey into poor mental health, or potentially antisocial behavior, or potentially substance misuse. And so the idea that we could bring social prescribing into a healthcare environment with community services is really appealing, because that way we can then help individuals become part of their community, help them really integrate, and hopefully stop that individual moving on to other more acute needs.
Agradecemos mucho.
We thank you so much.
Vamos a tener una última pregunta que nos están llegando por escrito, y es sobre la salud mental.
There's a question in writing on mental health of workers. Please answer the question, and with this, we will finish this dialogue. Come on, you can get started if you have any comment to this question.
About work, did you say? Sorry.
Sobre la salud mental de los
On the mental health of healthcare workers.
We did a very large number of studies during COVID and immediately post-COVID that shows we have an epidemic of mental ill health within our healthcare workforce. And this is not just associated with COVID, but this is also associated with the fact that healthcare itself is incredibly stretched in the UK, as it is in many places globally. But tends to happen is the sense of either moral injury at an extreme, or a sense of moral inability to offer services has a marked impact on those people who choose to offer healthcare. And the fact that we have higher rates of depression, anxiety, some PTSD associated with many of those sort of episodes during the pandemic, but also increased rates of alcohol and substance misuse compared with other workforce sectors, I think sort of bears that out. The NHS is awash, or has been awash, with a number of wellness initiatives trying to focus on the workforce. But there's also a little bit of I think fatigue around that kind of thing, where many in healthcare I think one of the ways of addressing this would be not just to sort of say, here's a sort of well-being intervention for your hospital or for your workforce, but to have properly resourced, properly funded, properly supported healthcare structure that enables people to do their job properly. That's the way to go about it, I think.
Just to add very briefly to what Sean said, I completely agree. A lot of the work we do with organisations involves providing space for mental health professionals to be able to think about, reflect upon, and process their work and the impact that the work has on them, which, as I mentioned earlier, can be traumatizing, particularly if it's over a long time or if they've dealt with a particularly serious or difficult event. So helping organizations put cultures in place that provide safe, supportive structures for their workforce is really important and something that we do a lot of, and is has a significant dimension in our education and training provision, where we're trying to build the internal capacities of individuals to manage the stresses of their work. But important to recognize it's an organization's responsibility to provide appropriate care and support of their workforce, not for them to be relying alone on the resilience of their workforce.
Muchísimas gracias. Ahora vamos ya a dar cierre a la...
Thank you very much. Now we will close the meeting, but not before asking each of you. Dr. Butler and Dr. Cuba had to say goodbye, but we would like to ask you to give a concrete final message in 1 minute. What could be a takeaway message from each one of you?
Perhaps I'll go first.
Por favor.
I mean, I think probably some of the themes that we've spoken about today are about, if you want to build a mentally healthy population, we have to recognize, as you mentioned, that we have different needs in different generations. And so that there will be a targeted approach with a universal goal to create a mentally healthier population. And I think our advice would be not to look at the lowest level of service for everyone, but to co-design with each group to identify their wants and needs. So that would be my piece of advice.
And I think I would add to that and mention the importance of early intervention and building good quality services within communities that integrate services, organizations, professional disciplines and settings as much as possible, that are co-produced with members of the community, so that health services are working with their communities and not doing to their communities.
And I would agree with everything that Tim and Paul have just said, stealing my thunder. But I suppose that on a final point, also to say the importance of groups of people thinking about this stuff, sharing thoughts and ideas, which is why a seminar like this is so incredibly important. I really want to know all about Peruvian healthcare system and the initiatives that are currently underway across the country. And so one of the things that I would really like to do is just kind of encourage those of us who are thinking, working and trying to do something about this to talk to one another more.
Muchísimas gracias. Les comento que hemos recibido...
Thank you very much. We've received several questions, many questions actually, but we don't have time to answer them all right now. However, for those of you who have sent your questions, we will bear them in mind for future activities, and we value the participation of everyone. We would like to thank the Embassy of the UK, dear Rodrigo, the speakers, dear friends, the experts who are here from the Ministry of Health, and very especially for the presentations that you've shared with us. We've received congratulations through the chat boxes of Facebook and YouTube Live, and I wanted to share this with you. To all of the participants, to all of the members of the Horas CONU, especially Rob, Espejo, Milagros, Ruby, Yaneth, and I don't want to fail mentioning Yadira Salas and all of the members who've been engaged in the organization of this event. Well, thank you very much for your support. And all of the people who have been here actively participating in this meeting. This event would have not been possible thanks to the commitment to Andean and Latin American integration. Now, I would like to give the floor to Dr. Maria del Carmen Calle to close this webinar on behalf of the Andean Health Organization, Hipólito Unanue Agreement. Go ahead, Dr. Calle. I'm sorry, Dr. Peña. He's always committed to the Andean integration and the development of the country and development of health. He's always here in all of the webinars. I'm sorry, I didn't give you the floor, Dr. Peña. The floor is yours now, doctor. Thank you very much. I lost him. I would like to thank the brilliant speakers who have joined us today and actually reiterate our commitment. If we well express, we've made a lot of progress these past years, only putting mental health as part of the political agenda, but also generating real changes with a community approach and always based on prevention and timely care, as has also been expressed in the respective presentations. We are fully aware that this is still a long road to go, and in this sense, we need to count on your contribution, your expertise. We are very grateful for being in this webinar with all of you, which has been organized by the Horas CONU and the Embassy of Great Britain. And once again, we would like to reiterate our commitment to provide better health care to our people. Thank you very much, Deputy Minister. And something else is not having thanked Andrea from the British Embassy.
Well, my first word is to thank deep, profound thanks to our panel members, our speakers. Thank you very much for your generosity of sharing this extended time with us and by telling us what are you doing, what are you working on, what achievements are you having. I would also like to thank all the staff from the Horas CONU. I would like to thank the apprentice of the Vice Minister of Public Health, because this is an endorsement that we receive and that gives us the recognition of what we're doing to other members of the Ministry of Health, from the hospitals and institutions of mental health. Very special to the British Embassy in Peru. We started 3 months ago, I believe, a little bit more than that. This is our third webinar, and it's getting better and better. Let me tell you, we're getting better and better. I would just like to remind you that we have a major commitment to mental health from the Andean Health Organization, Hipólito Unanue Agreement. We are fully convinced that without mental health, there's no health. And also, we are convinced that we may have people who have mental disorders and are living healthy. And there may be people who are healthy with no mental disorders and may go through moments of their life with issues, mental issues. So there's a whole array of combinations, but it is clear for us that there is no exception. 170 inhabitants of our countries, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, they have the right to the highest level of health possible. And we are fully convinced that health is not only a sector area, it has to do with everyone. So thank you so much for being with us, for staying for so long. This is one of the longest webinars that we've created, and we ask those participants to get ready for December. At the end of November, or the first week, the first days of December, we're going to organize the 3rd International Congress of Mental Health through the course of life, and we would love to have you participating. So we are committing you from now. We will invite someone to you to Lima, but we will try to have you here. Let's not forget that May 9 is our next webinar. It's also a very important topic. It's related to school bullying, new challenges to tackle school bullying. So see you on the 9th at 11 a.m. Thank you very much. See you soon.